Good morning to everybody. In these last two lectures, we are going to sum up all the concepts about protective ventilation, especially in the OR, and we want to really focus on what can we do to protect the lungs against mechanical ventilation. So, as we said in the first two lectures, we want to emphasize what is specific from the intraoperative ventilator-induced lung injury. That is not exactly the same procedures that when you are ventilated and distress syndrome. If you can remember, I think what really makes a difference is like in the world of distress syndrome, atelectasis trauma and atelectasis are not so important. But in anesthesia is routinely. Every time you intubate a patient, you create atelectasis after induction. So these specific mechanisms create some difference in intraoperative billing. For example, the problem about atelic trauma and cyclic tidal recruitment is huge in anesthesia and is one of the most important factors for Billy during the war. On the other hand, barotrauma, that is the damage created by pressure. Remember that at the beginning, the first pressure we always want to control is plateau pressure, and obviously the less the better. But now we know this is not enough. When we've been talking about the stress and strain, finally inside of the OR, the most easy parameter to control and is at the same time the key stone to protect the lungs against mechanical ventilation is driving pressure. You can get driving pressure all around the world in any kind of ventilator. You don't need any specific tool for that, and it can be measured from China to the States and from South Africa to Spain, and everybody can control that. Not that it was happening with mechanical power. Atelectasis is great, and this is a concept that usually is not very well known, and please, this is very, very important. For the ones who say, no, don't use PEEP because we create overdistension, it's just the opposite. The more atelectasis you have, the more cyclic tidal overdistension. So overdistension is related to with the amount of atelectasis at the same time. Remember this concept that we went over it. And obviously biotrauma, that is crucial in distress syndrome, usually is not that important in anesthesia. Obviously there are always exceptions like polytrauma or very aggressive surgeries. So we are going now to review, in my opinion, one of the most important parameters to know how to set during mechanical ventilation. That this is the famous concept of PEEP. And in my opinion, the problem about PEEP is probably we are not doing the right questions. And we are not doing really to get through what PEEP means. So I think if we really want to understand what is really PEEP doing inside of the lungs, the first thing we have to know is really all the mechanisms that it works and what is PEEP for and what is not PEEP for. So the first thing is all the papers that we've been going around about high PEEP and low PEEP is a totally wrong concept. Why wrong concept? It's simple. Put together a neonatologist, a pediatric anesthesiologist, an anesthesiologist, adult anesthesiologist, and an intensivist especially from the point of view of open line approach. If I say to an neonatologist what is high PEEP for you, they're going to say, oh, never ever more than 5. And I mean 5. If you ask for an intensivist in adults, if 5 of PEEP is high or low, he say this is not PEEP. This is nothing of PEEP. So this is, in my opinion, the first wrong approach. Please stop follow papers saying high PEEP, low PEEP. This concept is totally wrong. And so if we start with a wrong concept, it's impossible to get good conclusions. Second, do you really think from the physiological point of view that there is a magic peak good for all the patients? And if it's the answer, it cannot be other, like obviously no. not. It's impossible. It's impossible to stabilize with the same amount of PEEP all the lungs, because the functional residual capacity and the characteristics of the lungs are totally different. So why are we trying to find out this kind of magic PEEP? So another group of clinical randomized trial that you can remove and throw it away is all the ones who say, what is the best PEEP for abdominal surgery? What is the best PEEP for obese patient? What is the best PEEP? All these approaches are totally wrong. So exactly same. There's a magic PEEP for all the distress syndrome? Obviously, it's not. So does everyone need the same PEEP for the same amount of PO2? So even for one simple parameter, that is to get oxygenation, we know from physiology that the same amount of PEEP is not correlated with the same amount of oxygenation. So even PEEP table is I'm very sorry, but it's not based on physiology. So if you can follow this approach, it means like probably 90% of the papers about clinical randomized trials of PEEP, really, it doesn't make any sense. Now you perfectly understand the consequences. After more, this is the first important, one of the first suitors, big clinical randomized trials about the use of PEEP and how to set it. It's in 1975. Nowadays, even after 50 years with the PEEP in our ventilators, we still, as clinicians, routine practice, we don't know how to set it. If you ask your colleagues, how do you guide your PEEP settings? Even they get blocked. That's why it's so common that this person, no, I go for the PEEP of 5 for everybody and everything is solved. You know why? Because it's the shortcut. It's a simple way not to affront a very important, crucial question. It says, how can I guide my PEEP settings? So I'm very sorry. This is what's happened. This is a slide from my friend Paolo Pelosi. I'm very sorry. This is when you get a wrong question, no matter what you do and how many patients are inside of this study, the consequences are going to be wrong. So really, this approach like a PEEP is dead, and a PEEP it doesn't work. It's totally untruth. I think the story about this, as we said before, is like probably we have to change our approach. Why stop thinking about randomized clinical trials? Instead of that, really get deep in what is PEEP doing in the lung physiology. So please go through lung physiology, understand how the lungs works, and then understand what is PEEP for and what is not PEEP and what is not for. And then probably we can totally change our approach about PEEP settings. So the first thing is we have to totally be 100% sure is why we have atelectasis. So you have atelectasis in the OR, on intensive care, every time the functional residual capacity of the lungs goes down, and with at the same time increasing in closing volume, or just for only one reason. So every time you reduce functional residual capacity, you are prone to atelectasis. Every time you have increasing in closing volume, you have atelectasis. I always make the same example. Imagine a pregnant woman with healthy lungs. Obviously, in the last 3 months of the pregnant period, you have a clear reduction in functional residual capacity because the baby is increasing the abdominal pressure, reduction, compress the diaphragm, and reduce functional residual capacity. That's why every time you intubate a pregnant woman, you have a huge amount of collapse and very fast desaturation. But the lungs are totally normal. Now imagine after the birth of the baby, 2-3 months later, the same good lungs, but this poor lady have a 3-4 distress syndromes with 3-4 consecutive pneumonia, and then they go for pulmonary fibrosis. and the elasticity of the lungs have changed totally. In this case, functional residual capacity is not reduction, because now she doesn't have the baby inside of the abdominal cavity. The story is like the characteristics, the stability of the lungs have changed, and now you need more of functional residual capacity, you had or an inspiratory lung volume, to really not have atelectasis, because the closing volume has increased. Just the opposite. Every time, how can we can keep our lungs open? Because we have enough or higher functional residual capacity than the closing volume. This is due to because we have good elastic lungs with good surfactant, very well distributed, and at the same time we have a good diaphragm, keeping the abdominal cavity in his position and keeping the functional residual capacity in the right place. And that's why we always work with our open lungs. So based on this concept, every time we have a decrease in functional residual capacity plus increase in closing volume, because you have a reduction in the stability of the lungs, or only one of those things, you are prone to have atelectasis. So what happened with neonates? And I really recommend to master physiology of neonates or lung neonates, because it really teaches you a lot about this process, about the collapse process. When a neonate birth, healthy neonate, the relation between functional residual capacity and closing volume is very close to instability. So if in perfectly well conditioned, after 48 hours that the surfactants started to well produce and distribute, the lungs are quite stable, but just in the limit. That's why neonates, or if you have anesthesia in any healthy neonate, or during any other procedure, you give sedation or whatever, these healthy neonates go for collapse. Why? Because the functional residual capacity is much lower than the closing volume. Okay, so if you master, so there should be something why a neonate that at the beginning, just with the birth breath, their lungs are not stable. There should be something to avoid atelectasis, because the relation between functional residual capacity and closing volume is very close. So any reduction in functional residual capacity, you have atelectasis, and increasing in closing volume, you have atelectasis. So what is this? Let's see it. This is one of my first research that I've been working with isolated lungs from the very beginning. Why? Because I really want to master how the lungs works. And if you see it, you perfectly understand immediately. This is a study done in adult lungs of a pig, comparing with a neonate lungs of a pig. If you ventilate both of them at the same time and you disconnect it, you perfectly realize two processes. One, constant time. The constant time of a neonate is very small, less than 0.4. The inspiratory and expiratory time is 0.4 seconds. Comparing with an adult, that is up to 2 seconds. You are going to see how the lungs of the baby collapse very fast, now fully collapse. And the second is how stable the relation between functional residual capacity and closing volume. Adult lungs is quite stable, but the neonate don't have any stability. If you depressurize, that's because the relation, what we said before, the relation between closing volume and functional residual capacity is quite unstable. That's why if you disconnect any neonate, you immediately go for collapse. And so there should be something to avoid this process. This is what is called glottic closure reflex. It's a very well-known reflex that usually people don't know that much. And this is due to we avoid atelectasis. This is what is called Autopip. So imagine we are alive as a species thanks that we are able to program Autopip. So for the ones who said PEEP is dead, if PEEP doesn't exist in human being, we are dead. We don't exist. We don't exist as a species. All the neonates go to die because they cannot stabilize the lungs by themselves. So they have to close the glottic, that is called this reflex, glottic closure reflex. When the neonate is awake, they close the glottis before the end of expiration. So what is really creating? They are stopping the expiration and create autopip inside of the lungs, only of 2-3 centimeters of water. And with this only 3 centimeters of water, we can stabilize the lungs and avoid atelectasis. So you have all the answers, all the big question, everything is lung physiology and neonates lung physiology. So this is a second very nice approach, is how can I know, clinically speaking, if a lungs are atelectasis or not? Once again, learn from neonates. There is a very nice concept, it's called apneic oxygenation time, that we know through neonates that is totally proportional direct to functional residual capacity. So what does this mean? Remember, every time you intubate a patient, what's happened? That in less than 30 seconds is totally dark blue. Why? Compare with an standard adult that can remain above 91 of saturation for 3-4 minutes. So why? Because the functional residual capacity of an adult is much higher than a neonate. All of these concepts are totally measured. It's perfectly well known, but you have to go through physiology. I love this paper that I highly recommend all of you master it. It's a very nice study who measured the functional residual capacity after surgery. And as you can see here, depending if the incision is in the lower abdominal area or in the upper abdominal area, you see the repercussion on functional residual capacity. So the story about functional residual capacity of surgery is not only after induction. We all know that. When you intubate the patient, you create a relaxation of the diaphragm, and the abdominal cavity push the diaphragm to the thorax and create a reduction in functional capacity. But for the ones who think they say it's magic, no worries, because whenever you extubate the patient, everything will be solved. Totally untruth. And it's perfectly well measured. This paper showed to us that the reduction in functional capacity can remain in the patient for 2, 3, 4, even 10, even 12 days. What does it depend on? It depends if the patient starts to walk in 2 days, 4 days, or 1 week. So the reduction in functional capacity is crucial during the perioperatory period and remains there until the patient starts to re-walk again. So now we are going to see and to master what are the real effects of PEEP or CPAP. Well, this is a video that you can get through internet, a very nice study from a German lab who showed to us what are the real effects of CPAP. CPAP or PEEP, whenever you don't have it, the lungs go for collapse during expiration. But if you set the PEEP that these lungs need to keep it open, well, the effect is that the lungs don't go for collapse during expiration. But the second thing I want you to master and visualize is like PEEP doesn't recruit the lungs. Just the opposite that you think in this video. But if we are going to see it twice. The effect is to open the lungs is not PEEP or CPAP. It's the maximum transpulmonary pressure. If you remove the CPAP, you have collapse during expiration. So CPAP or PEEP is to prevent the formation of atelectasis during expiration, and but not to reopen the lungs. We are going to see again because I think this is crucial. So no PEEP, like you have collapse during expiration, but the lungs are open due to the maximum transpulmonary pressure, the plateau pressure, the high pressure. And with PEEP, you avoid the collapse whenever the lungs are open during inspiration. Open, no close. Open, no close. Okay, you see it here. It's a very nice, I highly recommend to go through these studies with isolated lungs. Isolated lungs always teach you all the physiology about the works of how the lungs works. Okay, this is one study done in my lab that I did it on purpose to really remove one very well-known wrong concept about that PEEP set a PEEP of 5 and everything is solved. I have heard this wrong concept all around the world. And it's totally untruth. This study, what we did, it was get isolated lungs from rats, healthy isolated lungs for rats, and we put a video camera, and then after 3 hours, we measure in a plethysmography the functional capacity of the lungs. After 3 hours of PEEP of 5, nothing have changed. So you don't recruit a single alveoli. I'm very sorry if you have been thinking about this, but it's totally untrue. That's what I told you in my courses: physiology, physiology, physiology. First, master physiology, and then read papers. So whenever you go for 10 of PEEP, after 3 hours, nothing changed. Then I went to PEEP of 15 of PEEP, that if I told you I put you an exam, I'm totally sure that all of you say, oh, with 10 of PEEP, oh, everything is fully reopened in 5 seconds. After 3 hours of PEEP of 5, nothing changed. Plus 10 of PEEP, 3 hours more, nothing changed. And whenever you reach PEEP of 20, CPAP or PEEP of 20, is whenever you start to increase functional residual capacity. This is pure physics. This is not magic. It's physics. This is what is called critical open pressure. There is a maximum pressure. Beyond that, you start to reopen some amount of atelectasis. And then beyond this point, that is 20 centimeters of water, more time you give, more lungs you recruited. But beyond this, but before this point, nothing happened around recruited. So all the people who think like a PEEP of 5, 10, 15 is going to recruit that atelectasis is totally untruth. The critical open pressure, transpulmonary pressure, start beyond 20. But this, remember, this is not the maximum alveolar pressure, because in this case, we don't have thoracic cage. So in this case, alveolar pressure equals, by definition, to transpulmonary pressure. But this is not the reality. Whenever you are working with lungs inside of the thoracic cavity, the pressure you see in the ventilator is not the same as the transpulmonary pressure. So PEEP never ever recruit a collapsed lungs. Well, this is one of our studies in the lab that I did on purpose to remove another fake news, fake concept all around the world about the PEEP. I have heard in my life so many times saying, I don't use PEEP more than 5 in neonates because you are going to create pneumothorax. And I've been taught in my life around this wrong concept. So I make this research. In this research, what I did was compare 2 ways to create pneumothorax. Obviously in rabbits. So we, in one side of one group, there was we reach a PEEP of 20, and then we stop, and then we increase driving pressure until we break all the lungs. And in the other side, we keep the driving pressure constant because we increase the PEEP and the plateau pressure at the same time until we break the lungs. And as you can see here, there is a huge, significant difference. If we reduce driving pressure, and driving pressure is constant, the maximum pressure to start to break the lungs is beyond 65. Much higher than if we are giving a high driving pressure. If we give a huge amount of driving pressure, the lungs create pneumothorax much with pressure much lower. So the story about this is like we all know that the worst pressure to create barotrauma is plateau pressure. That's for sure. The higher the plateau pressure, more risk to have pneumothorax. But the second most dangerous pressure to create pneumothorax is not PEEP, it's driving pressure, once again. So if you want to reduce the risk for pneumothorax, reduce plateau pressure and reduce driving pressure. Don't reduce PEEP, just the opposite. What is the main consequences of this study is that the higher the PEEP is, the lower risk to create pneumothorax. Just the opposite that we've been taught all our life. Okay, another important concept from physiology about how to set PEEP. This is a patient, a distress syndrome, and this is a study from Joao Borges, and he showed to us how exactly the same patient, exactly the same amount of PEEP, just before and after our crude maneuver, the compliance changed totally. In this case, because probably they have a huge amount of atelectasis due to a disconnection or whatever, you can see perfectly here how the same PEEP after our crude maneuver almost doubled the compliance. So the consequences would be that the driving pressure here and there will be totally different. This one will have probably half of the driving pressure that this one. So please, another concept. It doesn't, I'm talking about the amount. It's not only the amount of PEEP. The other question we have to master is the way to set PEEP. If you set a PEEP after a fully open lung or a collapsed lungs, the consequences on the side of the lungs and about the belly is totally different. Remember, it's not only important what it comes from the ventilator, the PEEP, plateau pressure, driving pressure, tidal volume, flow, whatever. This is only one part of the equation. This is what it comes from the energy. This is what the energy you are delivering to the lungs. The other part of the equation is how the lungs are homogeneous or heterogeneous. So the other part is how the lungs are stabilized. If the lungs are perfectly well homogeneous and it's perfectly well open, so the same energy is going to much better distributed, and then the effect are going to be much lower. So please remember, it's not only the amount of PEEP, it's the way you set PEEP before. So how can we guide PEEP settings? Say, okay, Javier, because probably if following all the approach we are doing, yes or yes, the answer is we have to individualize PEEP settings. There is not a magic pick for all patients. There is not a magic pick for all procedures. We have to know how to set PEEP in every single patient. Even in the same patient for today and tomorrow, things can totally change. Even in a DOR, from the situation before the pneumoperitoneus in a laparoscopic procedures or the situation before and after a Trendelenburg can change totally. So the best way, clinically speaking, because it's very simple, it doesn't mean that it's going to be the perfect way. I say the best way because it's the most, because everybody can do it, because all of you, and we all have dynamic compliance in our ventilator. So the best way, or one of the approaches, is best lung mechanisms. So the best elastic point with the highest dynamic compliance, that will be the best PEEP. Second, in volume control ventilation, the lowest driving pressure. Really, it means the same that the other approach, but have some specific. That's why I say it. Flow meters and barometers are two different ways to measure the same different things, but it's the same approach. But barometers are always more precise, because nowadays really to measure pressure is very simple. There is not many problems around there and interferences. But flow meters, always to measure flow, is a little more tricky from the point of view of engineers. There are a lot of problems around there, like compressive volume, temperature, humidity. All these things can change the way that flow meter works, and that's why they're not so always in those circumstances the same accurate that barometers. So if you work in volume control, but only if you work in volume control, instead try to find the best, highest dynamic compliance that have to measure flow, you only have to find the lowest driving pressure. And I love this way because, as we said, driving pressure is the most critical pressure to create damage on the lungs. So really to have the PEEP who create the lowest driving pressure, I really love this approach. Second, obviously, the less shunt. So the best PF ratio or best saturation VO2 ratio is another very nice way to get the best PEEP. Less dead space, very simple if you have arterial blood analysis. So a simple way to measure this is just the less difference between PCO2 and end-tidal CO2. And obviously the future will be your eyes. Your eyes always tell you the right answer, and probably it's because you, besides that, you feel very confident about this. So we have to master and to do training about lung echography, lung ultrasound, because it's a very nice way to set the minimum PEEP that you can check in the back part, in the basal part near the diaphragm, that the lungs are fully opened. Probably is the best PEEP. And obviously, this will be the master key method. But the story is expensive. Is to have, if we all imagine in the future that all the ventilators can be sold and they have incorporate electroimpedance tomography and everybody can do it. It's so simple. Nowadays, they have a special software. We are going to see it that you only have to push a button and it's done. So I really like this method. This is another tool to help you to set PEEP. That is SAfy curves. This start in pediatrics because in pediatrics, in children, small children, it's very difficult to get arterial blood gas examples. It's quite difficult, and really we try to avoid to do it. So we substitute the PO2 from SAfy for saturation of oxygen. In this case, it's not that precise and puffy, but we can do it with this curve. If we measure 3-4 points of the patient with different VO2, the way that I highly recommend to do it is very helpful, for example, in some adults under laparoscopic procedure that then compliance is not working anymore. And then the only thing you have to do is to start in 21 of saturation, 21 of VO2, then allow the patient to stabilize for 2 minutes, and then you put a dot of the saturation. Imagine the saturation in this case is 95. So it will be this dot. Then I move in to 40%. I allow the patient to stabilize for 2 minutes, and imagine that the saturation is 97. No, so and then you do it with, for example, 70. It doesn't matter. I always do it in a step of 2 or 3 because I mean otherwise it takes a long time. So with 3 dots is enough. So imagine in this case it was 95, 75. It means around that the shunt is around 20% and 50%. So see how easy it is to set. If we have a shunt and even to quantify, and this can give you a very nice information if I have a lot of atelectasis, if I had to set another level of PEEP after that. So finally, this could be very, very, very nice. And this is the future. The future, we have the option and the money to buy all these devices. But see how easy nowadays. This is electroimpedance tomography. Electroimpedance tomography, as you know, is a belt with different electrodes that receive the electricity, because some of them give electricity and other ones detect this electricity. So the story is like you are going to see the resistance. Obviously, air is not conducting electricity, and solid fluids, a solid organ, conduct electricity very well. So this, based on this simple concept, the electroimpedance tomography can tell you if you have good air, I mean if you have the lungs are well aerated, or if you have atelectasis. White means a lot of air. Blue even can be a little of overdistension. Blue is very well aerated, and is black. The black area is because it's solid, or it's an area who don't conduct anything. So and then they can measure overdistension at the same time. So see how simple with this tool. You never fail, because you see they see the area according when you are first. This is a recruit maneuver. You open up the lungs, fully open the lungs, and then you start to reduce the PEEP in the decreasing steps. Whenever you decrease the PEEP, obviously at the beginning you don't have any kind of collapse with high PEEP, but then you start to have overdistension. So here you have everything open, but a lot of overdistension. So I want the perfect balance between collapse and overdistension, and this tool tells you perfectly, because now, for example, it's telling you, okay, still there is not a huge amount. Now you have a little of collapse in the back part and still overdistension. So probably the perfect PEEP is something between this one and this one. And then when you graph, the conclusion is very simple. In this case, this is the perfect point. So this is the perfect PEEP for this patient, in this case 10. So about PEEP, like a take-home message for these first lectures, we can say without any doubt and without any kind of clinical randomized conclusion. I mean, this is not, all this information is due to pure physiology. PEEP has to be programmed individually, yes or yes or yes. Any other message, it doesn't come from physiology. For this patient in this right moment, so forget general rules, all of them are wrong. PEEP only works to keep the lungs open. It never reopens the lungs, so don't try to set some amount of PEEP to reopen lungs. If you have to reopen lungs, you will have to go through a recruit maneuvers. As we talk in other lectures, but recruit maneuvers to reopen the lungs, PEEP is to keep the lungs open. Open has to be programmed always after a previous open lung because, recruit maneuvers should be performed before setting PEEP. For me, recruit maneuver is not only to improve mortality, reduce postoperatory pulmonary complication. No. It's about, for me, is the tool, the natural tool, the clinical tool to know what is the PEEP I have to set in this patient in this moment. So this is the way, remember, the way we set PEEP is best or highest dynamic compliance, less shunt, less dead space, sick with lung echography, electron impedance tomography, and why not in the future the best right ventricular function. Thank you so much.